here, where under this diagnosis, this big diagnosis of breast cancer, in fact, what we have is our luminal breast cancers, A and B, which are largely treated with hormonal therapies, with or without chemotherapy. We have the HER2 breast cancers, which we'll discuss in some detail, which are treated with anti-HER2 therapies, and often with chemotherapy. And then we have what we call the triple negative breast cancers. And those are the breast cancers that don't have estrogen receptor, they don't have progesterone receptor, they don't have HER2 expression. So these are the breast cancers that have the poorest prognosis and lack the kind of biologically based therapies that we'd like to be able to deliver. So that then brings us back to look one more time with that understanding at the current epidemiology of breast cancer, to remind you that the likelihood or the rate of these particular molecular subtypes is also rooted in ethnicity to a certain extent. So for example, the luminal A breast cancers are extremely common in non-Hispanic whites, as you can see here, less common in the other three groups that we can take a look at. Not a whole lot of difference in the likelihood of HER2 breast cancer, the luminal B breast cancers, as you see here. Again, HER2 breast cancer is about the same across all of the groups. But here on the basal breast cancer front, you'll see that African American women are especially prone to that kind of breast cancer. And that's obviously a very difficult breast cancer to treat. Although we're internists, I do want to remind you that there have been remarkable advances in breast surgery over the last century or so. And this is thanks to really wonderful evidence-based research that's been done by our surgical colleagues over a long period of time. And so this just reminds you sort of historically that I personally started my career at Johns Hopkins, which was of course the home of the Halsted mastectomy, at a time when, if you kind of look qualitatively, more surgery was the rule of the day. Over time, as we went forward in the early part of the last century, the goal of having even more extended surgery was felt to be appropriate. And then only as we came into the 70s and 80s did it become very clear that, in fact, more surgery was not the answer, that most breast cancers are, in fact, systemic diseases from the get-go, and that trying to optimize and limit local therapy was going to be a very reasonable place to go because it was the metastatic disease that was life-threatening, not the local disease. So Alberto Veronese in Europe and Bernie Fisher at my old home at Pittsburgh were both major proponents of breast conservation surgeries and bringing them into clinical practice based on rigorous clinical investigation. And then with time, we came to question how much we needed to with regard to the axillary lymph node management. And so thanks to people like Armando Giuliano, we've now come to a point where for many women, removal of the primary breast tumor and an examination of the sentinel lymph nodes, just those sentinel lymph nodes, and often not the removal of any other lymph nodes, is going to be the treatment of choice. And you'll remember that our patient that we talked about today had exactly that procedure. Now, we are 18 days into our latest version of our staging system. You know that all cancers are staged usually according to the TNM system, which has been in existence for many, many, many years. We do, as a matter of routine, update those staging systems to reflect our new knowledge about what's going on in a particular disease type. In the world of breast cancer, truly, we're in our 8th edition, and it started on January 1st of this year, so we're still struggling a little bit to try to figure out how to apply this. Remember that the goal of staging is, first of all, to help to provide prognosis information for the patient and to help to think about what her therapy might be. But it's also to allow us to have a common vocabulary so that we can compare between various studies and across the world as we think about care of cancer. So traditionally for staging in many diseases, including breast cancer, we've used the traditional TNM system. Remember, tumor, nodal involvement, metastasis. In the current staging for breast cancer, we're going to find that the big changes that we're building on this traditional staging to include biomarkers. There are two types of staging that are available to us now: clinical prognostic staging and pathologic prognostic staging. And here you can see the two differences. Clinical prognostic staging is done before any treatment, at the time of diagnosis. It involves a history, a physical exam, imaging, usually breast imaging in this particular case, biopsies to establish the diagnosis, and a careful evaluation of the standard biomarkers, including tumor grade, estrogen and progesterone receptor staining, and HER2 status. The advancement here is our wish now to actually move more towards pathologic staging, and this is done post-operatively, so after the completion of the surgery. It takes advantage of a pathology-defined TNM, right, what the pathologist measured and looked at underneath the microscope, as opposed to over here where it was clinical. And it takes into account all of the biomarkers that we talked about here, as well as the use of multi-gene panels, which we'll discuss in a few moments. In this country, where we have a lot available to us, pathologic prognostic staging is going to be the preferred way of staging. We know that that may not be possible on a global perspective, and so other parts of the globe may choose to take advantage of the clinical prognostic staging that you see there on the left. But we'll be doing this going forward. And that's because we understand that these biomarkers are an important component of helping to predict prognosis for a particular patient. Now, there are a ton of questions we could talk about today. I'm only going to talk about the management of early breast cancer, which is the majority of breast cancer. Here are a lot of topics that I would cover if we were doing an oncology board review course, which we're not. And so I'm just going to pick topics which are of interest to me and which I think will be of interest to you, again, as my internal medicine colleagues. And I'm going to start with the prognostic and predictive marker area because so much is going on in that area. We in breast cancer have actually been blessed for a long period of time with a large number of prognostic factors and predictive factors. And you remember, prognostic factors are those that you obtain at the time of diagnosis that help you to think about what the natural history of the disease would be. Predictive factors are those that you can identify that will help you to select for or against certain types of therapies. So we like to have both of them. Prognostic factors for breast cancer are pretty well known to you, haven't changed a whole lot: nodal status, tumor size, steroid receptors, HER2 status, the histologic grade, and the subtype. Any of the weird kinds of breast cancers usually do a little bit different. The funny histologies do a little bit better. Proliferative rate and age. Very young women or older women, much older women, are the women that do the most poorly with breast cancer. The predictive factors are actually a lot more important to us as oncologists because they help us to talk about what kind of therapy to use. And those include the steroid receptors, again, estrogen and progesterone receptor. They include HER2 expression. But these days, they often include multi-gene assays, and that's an area that I want to touch on. There's a proliferation of these assays that are out there. These are assays that allow us to look at expression of multiple genes simultaneously. And you can see a variety of them that are available to oncologists to use at the present time. And when they go out there, we usually think that they might help us to solve three different questions. One is to estimate prognosis at the time of diagnosis. The second is to predict response to chemotherapy. Should patients receive chemotherapy or not, especially in the setting of hormone receptor positive breast cancer. And then finally, as we'll talk about, there's a real move towards very extended adjuvant therapy, especially the endocrine therapy. And so we're hoping that maybe some of these things will help us to understand who needs 10 years of therapy and who might be able to get away with 5 years of therapy, for example. A lot of these are far from perfect. There's a wonderful discussion of this in the reference that I put for you at the bottom of the page there. I want to talk about just one as an example of how these things come into practice, and I've also picked the one that's the most common used in many practices, and that's an assay that's called the Oncotype assay. This is an assay that looks by RT-PCR in a reference laboratory at the expression of 21 genes that are felt to be extremely important in the behavior of breast cancer. So the expression is looked at in a proprietary formula, and taking advantage of clinical trial data from the past, they've been able to use this to come up with what's called a recurrence score for an individual tumor. This is done on the tumor. And you can see that in some cases this is going to be a low recurrence score. In some there'll be an intermediate recurrence score, and in some cases there'll be a higher recurrence score. And so this test is extremely important to us when we apply it in the setting of node-negative, receptor-positive breast cancers, our best possible breast cancers, because it gives us, first of all, prognostic information. You can see in the yellow here, for the women who are taking tamoxifen alone, that the low-risk women and intermediate-risk women had really extraordinary outcome with the use of tamoxifen. At 10 years, their chances of being free of distant disease was close to 100%. You can see, though, that the high-risk score predicted for women who had a pretty poor outcome in terms of recurrence with tamoxifen alone. And importantly, and where this has really come into play, is that it shows that for these poor risk women, if they take chemotherapy, in fact, their outcomes are considerably better. So the primary reason to use this assay is to try to help to select for or against adjuvant chemotherapy in women where you already know that they have a pretty good prognosis and where you already know you're going to give hormone therapy. There are a lot of these women, so it turns out that this is an assay that's used quite commonly in our practice. Now, these were smallish, these were retrospective studies, and so we actually did in the United States a very large prospective trial, which is still going on, to try to look at the value of this more critically. And so here's a trial, just to remind you how hard these are to do. This trial took 10,000 women of these node-negative receptor-positive breast cancers. They had Oncotype testing done on their primary tumors. And then those that had the low recurrence score went on to endocrine therapy alone. Those that had a high recurrence score went on to chemotherapy and endocrine therapy, but there was a lot of uncertainty about what to do with the vast majority of women who were in the middle. And so those women were randomized to take chemotherapy or not in addition to their endocrine therapy. Well, we're many years into this trial. And so far what we have is the outcome from the women who were assigned to the low risk group and the endocrine therapy. And I think that the thing that's gratifying to us from this particular study is no matter what endpoint you want to look at here, and here we can look at overall survival just to focus, and here's the full scale, here's what happens if you use a much smaller scale. You can see that the women who had the low recurrence score have an extraordinarily good overall survival and a very, very low risk of relapse. So this does confirm the value of this particular assay in identifying the very lowest risk women. Now, those randomized women, we're still waiting. That study is in blinded follow-up, so it could be a while longer before we understand the final value. And I want you to know that a parallel trial was actually done with similar women with node-positive breast cancer to see whether or not we could figure out whether all of those women actually need chemotherapy as well. And we hope that those results will come out sometime in the next several years. But this is the kind of rigor that's necessary to really bring one of these tests online to use in a decision-making capacity. With that, I want to move to endocrine therapy, which is the backbone for any patient who has positive estrogen or progesterone receptor breast cancer. And our agents that we can talk about are tamoxifen, the aromatase inhibitors or the AIs, or ovarian function suppression or ovarian ablation. Why can we do this? Well, we can do this because, of course, we have decades of really impressive work that has helped us to understand the estrogen signaling pathways. Here's now a decade-old slide to just remind you that we know a lot about estrogen as the ligand. We know that there are intracellular receptors with which the ligand can bind and then go in, lead to transcription of estrogen target genes. We also know that it's not all that simple, that there are probably mitochondrial genes that are involved, and there's certainly a lot of interaction with other surface receptors and other growth pathways. But this understanding has made it possible to really design targeted therapies across all of these steps. So we have strategies that allow us to decrease estrogen, take away the ligand, destroy the receptor, interfere with the ligand receptor interactions, or to target these alternative growth pathways. This drug, these are the aromatase inhibitors and estrogen deprivation strategies that we'll talk about. The drug fulvestrant destroys receptor, and the drug tamoxifen is an example of an interfering agent, and you'll see that we use all of these as a matter of routine. Now let's start with thinking about what we get out of it. Tamoxifen is our longest lived drug. We've been using it for over 40 years. It's the drug that interferes with ligand receptor interactions. And here you can see the results from an international consortium that's been going on since 1985, where we gathered all the results of all of the published and unpublished adjuvant therapy trials from around the world. So this is really a Herculean effort and all-inclusive. And so for this particular update a couple years ago, I want you to focus on what we can get if you give 5 years of tamoxifen, and that's evidence based on a lot of trials. We're looking at 15-year outcome, and we're looking specifically at estrogen receptor positive breast cancer because these drugs don't work in tumors that lack estrogen and progesterone receptor. And you can see in these trials that the women who were assigned tamoxifen had a far lower recurrence rate and a far lower breast cancer mortality than the women who were not. So this single pill, once a day, 5 years, can have a very profound impact on outcomes that are important to you and me. You can also see, though, that it isn't perfect, that there are still, unfortunately, a lot of women that die of breast cancer, even despite this therapy. And so in a most recent analysis, one that just came out a couple of weeks ago, actually, we had the chance to take these data sets and try to extend them to either longer periods of time. And so in the New England Journal of Medicine a couple of weeks ago, we had this nice analysis that looked at 20-year risk of breast cancer recurrence and death after endocrine therapy. And the goal was to try to figure out if you could tease out who's who there, who are the people who are the more likely to recur late and who are not. And I think if you focus on this bottom graph here, where we've subsetted out by the number of lymph nodes that were involved at the time of diagnosis, you can see that at 20 years, for the women who had 4 to 9 lymph nodes involved, about half of them had died of breast cancer by the end of 20 years. So whereas the women who had lesser lymph node burden had a much better outcome. And so out of this meta-analysis of 60,000 women, it was clear that those things that are important at the time of diagnosis are still important 20 years later, the T size and the nodal status, that some of our biomarkers were less predictive than we might hope, And importantly, that it was the recurrence of the first breast cancer that was the life-threatening event, that such women do develop a contralateral breast cancer at a very low risk, and that was not related to their age or the status of their initial tumor. So this gives us some idea about who we might focus on as women who are at high risk for later recurrences. And then you say to yourself, well, okay, what can we do about that? I think one of the areas that has had a lot of development is looking at alternate endocrine therapies than tamoxifen, and the aromatase inhibitors have really come into our practice repertoire for women who are postmenopausal. Remember that postmenopausal women still make a little bit of estrogen, right, because of their adrenal glands and androgen production, and the action of the aromatase enzyme, as you can see here, which converts that androgen into estrogen. And so these aromatase inhibitors are very specific inhibitors of that aromatase enzyme, and they don't really mess up any of the other steroid receptor pathways, which is extremely important. So knowing this, and with some work to suggest they might be better than tamoxifen in these older women, a number of trials were done, and here you can see a meta-analysis of 32,000 women who participated in these trials. And again, it doesn't matter which outcome you want to look at. It was pretty clear that there was a reduction in recurrence, breast cancer mortality, and all-cause mortality with the use of the aromatase inhibitors. No difference between the three that are clinically available to us. No predictors of resistance, a huge disappointment to us. And the side effect profile, and we'll talk about that more in a minute, was what you would expect with these kinds of agents, particularly more fractures because of estrogen deprivation. So that means that we pretty routinely use these drugs now. And so one of the things we ask is whether longer durations of therapy would be better for what appears to be a chronic disease. And so over the last year or two, and just updated at our meetings in the last couple of weeks, are a number of trials with various designs that look at the strategies of tamoxifen with aromatase inhibitors for up to 15 years of therapy. You can see 4 international trials that have been done here that have been reported out over the last year or two. Here are all the details, but I'm going to call your attention here just to the part in the middle, looking at 5-year disease-free survival and that absolute disease-free survivals and the hazard ratios, and let you know that in some, they were not as optimistic as we might have thought of. It looks like across these trials that this is really good at preventing contralateral breast cancer, but it wasn't quite as efficacious as we might have hoped in preventing recurrence of the known breast cancer. And so we are struggling to figure out where to bring this into practice. I want to call your attention to a really lovely review that Rachel Young on our faculty, who joined us last year, wrote on this if you want to look into this topic a little bit more carefully, just published in JNCI earlier this month. Now, let's turn for a moment to those premenopausal women. Aromatase inhibitors don't work for them, right, because their estrogen comes from their ovaries. And so there's been a renaissance or a real recurrence of interest in whether or not ovarian suppression or ovarian removal strategies should be used in our younger women with breast cancer. Again, a couple of very large trials that have been done and were just updated in the last month. And here's one to give you a flavor of the work that's being done. And that's the trial that's called the SOFT trial, Suppression of Ovarian Function trial. This is a trial for premenopausal women. They got to have positive receptor breast cancer. They have to have the usual surgery and radiotherapy. And in these women, chemotherapy is often part of their repertoire, but not always. This trial tried to be all-inclusive, so it allowed women to get chemotherapy if the doctor and the patient thought that they should. It didn't make them if the doctor and the patient didn't think they should. And it stratified by whether or not patients had received that chemotherapy or not. You had to be premenopausal, though, at the end of your chemotherapy. Most, but not all women on this trial got one of the LHRH agonists, and the one that was chosen was triptorelin. So here's the design. The standard therapy for these women would be tamoxifen, tamoxifen plus ovarian function suppression. And then the other concept was if you make them functionally postmenopausal by suppressing their ovaries, should you use the aromatase inhibitor as you would in older women? And the one that was chosen was the drug exemestane. So here we are with this trial with the update a couple of weeks ago, looking now at 8 years of follow-up, which is getting there in terms of maturity. And you can see on the left the disease-free survival, and on the right the overall survival. So what this follow-up at 8 years has suggested is that the women who take ovarian function suppression with tamoxifen or with exemestane have a lower recurrence rate than the women who take the tamoxifen alone. But at 8 years, you can see there's not a shred of difference in terms of overall survival. So the impact right now is on recurrence, and what we don't know is whether with time that will translate into a survival advantage. No unexpected side effects. I want to point out that a lot of women didn't make it through their 5 years of therapy, and we're going to talk about this adherence question in just a moment. But this has certainly led our professional society to think a lot about how to apply this, and the guidelines right now for the use of this particular strategy in our young women from our professional society are that you might want to think about using this ovarian function suppression approach in women who have the higher stage breast cancers, the poorer risk ones. And you would not want to do it in the women who have the smallest breast cancers because they have a very good outcome, and you're probably going to add toxicity rather than benefit. If you're going to do it, we think you probably ought to do it for a long period of time. As we just talked about, it makes sense to combine it with either tamoxifen or the aromatase inhibitors. Now, a lot of this obviously leads to side effects, and so it's very important that we counsel patients about the side effects that they might encounter. And one of the beauties of having several different things to take advantage of is that you could actually help to titrate benefit and side effect profile to help the individual patient some of the precision of medicine that we'd like to practice. And so here you can see the side effects that we might expect with these three categories of agents. Of course, they're intuitive to you if you think about the pathways. Tamoxifen is a mixed agonist-antagonist in the uterus. And in the clotting system, it works as an estrogen agonist, so we see more endometrial cancer and clots. Ovarian suppression aromatase inhibitors reduce estrogen, and so you can see postmenopausal symptoms, osteoporosis and fractures. A lot of interest by our patients and ourselves in terms of whether there are any cognitive issues that we might see with these patients over time. And we're watching for some tiny little hint, perhaps, of whether there are cardiac events with aromatase inhibitors. But this is really useful when you're trying to talk to a patient about something she might take for a long period of time. Because these do require long periods of administration, there have been some nice studies looking at adherence, and here's one just to remind you about how important this is. Oncologists didn't worry about adherence for a long time because we gave everything IV, so we knew who got what. But now we're reliant on this with many of our patients. So here is a study done in Kaiser in Northern California. And they were looking at non-adherence to adjuvant hormonal therapy. And there's a consort diagram that you can look here, but basically they came down to a group of many thousands of women who had been diagnosed with breast cancer and prescribed either tamoxifen or an aromatase inhibitor. And they looked at prescription records as a kind of a surrogate for adherence to therapy. And basically what they found amongst these almost 9,000 patients is over 4.5 years, remember 5 years would be sort of a standard therapy, that a third of the patients discontinued their therapy altogether. 28% of those who continued were non-adherent, meaning that they didn't take 1 pill per day on a regular basis. And so at the end of the day, only half the patients actually got the therapy that we prescribed for the full duration and at the optimal schedule. And that's kind of disheartening. And it's particularly disheartening because they were also able to look at outcomes. And again, it's not a perfect study, but it certainly suggests that the less adherent you are, the higher your risk of mortality, largely from breast cancer. So this is very important to us as we think about trying to help patients take these therapies, because obviously adherence is going to be extremely important in ultimately predicting their outcomes. Also want to spend one moment on cost. I've chosen to do it only for this particular thing to remind you that another toxicity for patients sometimes is the finances. For a national presentation I did a year or so ago, I was actually asked to look at this, and at that time I went to the pharmacy where I worked in Pittsburgh, and I said to the pharmacist, if I came in and wanted to buy this, how much would you charge me? So remember that this doesn't take into account discounts and insurance and all those kinds of things. But you can see even these simple pills are not so cheap if you have to pay for it out of pocket with no kind of coverage. And if you're taking the LHRH agonists that I talked about, which are administered parenterally, you can see that they're pretty substantial when you look at a month of therapy. And so this also feeds into our patients often when they think about their adherence to therapy. Now, having done that, and again, hormone therapy, the first targeted therapy and one of the most important arms for any women who have receptor-positive breast cancer, as well as men, most of whom have receptor-positive breast cancer. So now I want to turn to the second biologic, which is the area of anti-HER2 therapy. Lots is known about the HER family of receptors. You know that there are 4 of them. They're shown over here. They're transmembrane receptors. In breast cancer, it's the HER2 gene that's extremely important, or B2. We know a lot about the way that they bind. We know in some cases about the ligands, and we know a lot about the intracellular signaling. And what that means is that we now have 5 FDA-approved therapies that can target aspects of this. 3 that are antibody-based that target receptors on the external surfaces of cells, as you can see here. And then 2 that are small molecule inhibitors that basically target these intracellular pathways. And so this gives us the opportunity to really think hard about how to target this very important growth pathway for about the 20% of breast cancers that overexpress the HER2 gene. And so these were developed in the setting of metastatic breast cancer. We know that, as we just talked about 20% of breast cancers overexpress this protein. It's usually because of gene amplification, multiple copies of the gene. We know that one of these agents, trastuzumab or Herceptin, which was the first one developed, is extremely important in terms of palliation in metastatic breast cancer in women who have HER2 overexpression. We also learned, to our horror and our surprise, that sometimes these things have unexpected toxicity. And in the metastatic setting, we learned that there was unexpected cardiac toxicity with this agent, especially if you used it with the anthracyclines, which are themselves cardiotoxic. And so these data allowed us as a global community again to come together around 4 pivotal adjuvant trials looking at trastuzumab added to chemotherapy in the setting of early stage breast cancer for women whose tumors overexpress HER2. I think the designs aren't particularly important to you, except to say that in each case they were randomized trials where the same chemotherapy backbone was compared to the chemotherapy with the addition of trastuzumab, and a year was chosen arbitrarily at the time, except for one trial where they actually chose one arm that had 2 years of therapy. These trials are now pretty mature. I'm showing you here the results from the combination of 2 of the trials that were done in the United States called the joint analysis, which looked at many thousands of women. And we're now looking at 10-year follow-up, so pretty mature, and at survival, and at disease-free survival. And I think you can see that the use of a year of trastuzumab has had a pretty substantial impact on survival, that we've seen an absolute improvement of 10% for women who have this type of breast cancer. Toxicity is quite acceptable. Again, much to our sadness, and we've looked very hard, we haven't been able to find other predictors of response beyond HER2 overexpression. And the fact that we haven't got perfect results has certainly allowed us to think about whether or not we should use other HER2 agents. We'll talk about this. We've also wondered, though, whether in some cases, if the outcome is pretty good, whether we could get away with less chemotherapy or no chemotherapy. So here's the first question, which is, can you do less and get the same results? And so here's such a trial that's guiding a lot of practice right now. A trial that looked at the smallest, the best behaved, if you will, HER2 positive breast cancers, node negative small tumors. And it said, we want to give the trastuzumab, the Herceptin. We want to see if we can give less chemotherapy. Let's give single agent chemotherapy for a short period of time. And again, doesn't matter which you look at, you can see that these lines are virtually across the top there, that these women do very well with this relatively less aggressive way of trying to treat breast cancer, less chemotherapy, and the use of trastuzumab for a total of a year. Lots of work that's gone on. Again, here are guidelines that exist for us to think about how to do this. In aggregate, our trials suggest that there's a 30 to 50% reduction in recurrence with a year of trastuzumab in women with HER2 positive breast cancer. I'm going to tell you parenthetically, we've done some duration trials. 6 months isn't as good. 2 years is no better. So we're at a year right now. That we use these combinations pretty routinely for node positive breast cancers and for the slightly larger node negative breast cancers. This is not a place where you make up your own chemotherapy. There are chemotherapies that are well established, and we should use those. Accurate HER2 testing is absolutely required. You are so reliant on your pathologist here, because these things work if you're HER2 positive. They don't work if you're HER2 negative. And as we'll talk about in a moment, there is some interest in whether or not we should use combination or sequential anti-HER2 therapy, and we're trying to figure that out. And here's the kind of work you got to do to bring those things into practice. 2 trials that led to FDA approvals of new agents over the last year for early breast cancer. This trial, 3,000 women who'd already finished their standard therapy, and then they were randomized to take one of those small molecule inhibitors, the neratinib, or a placebo for a year. And you can see that there is a statistically significant result. But if you go and look at the numbers, the difference is actually pretty small in an absolute sense. And so we're struggling with trying to think about where to bring this into practice. It's probably going to be for our women who have the higher risk tumors, the larger node positive tumors. This trial here looked at 2 antibodies. It looked at the Herceptin combined with the other antibody called pertuzumab or Perjeta that I showed you earlier. Enormous trial, almost 5,000 women. A little bit longer follow-up. And again, highly statistically significant, but the absolute differences are pretty small. And so again, we're struggling trying to figure out which patients to bring this into play for. And if you'd like to read about that, I want to call your attention to also a very nice review that Sasha Stanton from our division also just published, where she thought about what lies beyond APHINITY, one of the trials, as we think about the treatment of HER2-positive breast cancer, and then how you can use this knowledge currently. Bisphosphonates. I want to think a moment about bisphosphonates with you in the setting of breast cancer treatment. Now, of course, lots of women are going to get bisphosphonates for general bone health. But one of the things that's been very interesting is that there is a rationale for using bisphosphonates as a form of adjuvant therapy, so anti-breast cancer therapy. And the rationale is as follows, that bone is a common site of recurrence for breast cancer. We know a lot about using bisphosphonates in the management of advanced breast cancers as a way of trying to decrease skeletal mortality or skeletal morbidity. And we do that routinely. And then we have some preclinical literature in preclinical models that suggests that bisphosphonates may actually have direct anti-tumor effects. They may do negative things to tumor cells that are beyond microenvironment. And so with that information, there's been work that's gone forward looking at bisphosphonates as a form of adjuvant therapy. And rather than burden you with all the trials, I want to give you this single meta-analysis that looked at the worldwide trials again. Almost 19,000 women who were in 26 randomized trials, reasonable follow-up of about 6 years, looking at several different clinical outcomes that would be important to you and me, as you can see, and looking at the recurrence risk. If you look at all the patients who were on these trials, really the only thing that came out, as you can see, a little bit of a decrease in the bone recurrence. There wasn't any impact on breast cancer death. But if they did, this was a pre-planned analysis looking at pre versus postmenopausal women, what they discovered was that there was more of an impact in postmenopausal women with regard to recurrence, distant recurrence, bone recurrence, and breast cancer death. And so that means that in the setting of breast cancer right now, our current professional society guidelines would suggest that you would consider zoledronic acid at once or twice a year for 3 to 5 years, or clodronate. Clodronate is not available in our country, as you know, but these are global guidelines, and there are a lot of other places where you can get that in the world, an oral agent. But you consider this as a form of adjuvant systemic therapy for postmenopausal women, where you think that they may be taking other therapy in addition, so they're at relatively high risk for recurrence. In this case, postmenopausal includes women who had a natural menopause or those who are on those ovarian function suppression strategies that you and I talked about. At least at this point, the data to suggest the use of denosumab is not there. That may emerge with time as we do more testing. But I think that this has now caused us to think about introducing this therapy for some of our postmenopausal women as a way of trying to minimize breast cancer recurrence. Of course, you might think about bisphosphonates for bone health purposes for many women, including breast cancer survivors. Integration of other biologics. Just to let you know that there are a lot of coming attractions that if somebody comes back in a couple of years, you might hear about these kinds of things. In the metastatic breast cancer setting, there's a lot of work going on trying to take advantage of targeting new pathways. And once agents are established in that setting, then frequently they will come forward for testing in the early stage breast cancer setting. And so all of these agents have been or are being tested in early breast cancer right now, just to give you a sense of the spectrum that's available to us. Bevacizumab, the anti-angiogenesis antibody, is one that is near and dear to my heart. I have one of those sad circumstances where I was actually the senior author on the pivotal trial that got bevacizumab registered for treatment of metastatic breast cancer. And then I was still the senior author when it was removed by the FDA, when it was felt that it didn't have the advantage that you wanted to see in terms of survival benefit. We went on and tested in early stage breast cancer, nonetheless, totally negative trials, basically. And so we do not use bevacizumab for the management of early stage breast cancer in this country, although it is still approved in many European countries. The cell cycle inhibitors, the CDK4/6 inhibitors, and there are a bunch of them, including palbociclib, are now really taking us in metastatic breast cancer. We're using it routinely as a way to try to reverse hormone resistance in women who have receptor-positive hormone-resistant breast cancer, in addition to their hormone therapies. And because of their success there, they're now being tested in early-stage breast cancer to try to maximize outcomes. Similarly, the mTOR pathway has a lot of promise in metastatic breast cancer, and so some of those agents are being studied in early-stage breast cancer. And you probably heard that just earlier this week, the first PARP inhibitor was approved for metastatic breast cancer, the drug called olaparib. These are agents that seem to be particularly helpful in women or men that have BRCA1 or BRCA2 germline mutations. in the DNA repair genes. And so PARP inhibitors are now approved for metastatic breast cancer, and we are looking at these agents in the setting of adjuvant therapy for women who have those germline mutations currently. And then finally, you know, there's a lot of interest in immunotherapy across all types of cancer, and breast cancer is no exception. We wonder whether or not checkpoint inhibitors and other immune therapies might be the most useful in our triple-negative breast cancers, the one that lacks all those receptors. And so there are trials that are going on right now looking at the addition of checkpoint inhibitor antibodies in the adjuvant therapy of early-stage triple-negative breast cancer. So stay tuned. I think the next time you hear this lecture, you may hear that some of these have come online. Lastly, this is partly you, follow-up of early breast cancer survivors. There are a lot of them out there, 3 million plus, growing every day. They're coming to your practices. And I think often internists or other specialists who pick them up are wondering if there's anything special they need to do to follow somebody who's had early stage breast cancer. And I want to remind you that it's actually really simple, that there are very nice evidence-based guidelines. We've actually done some randomized trials over the year to suggest that for an early stage breast cancer survivor, on hormone therapy or not, that they need a regular history and physical examination, and we have a follow-up algorithm that we use in the oncology space. They do need to have routine breast imaging, both to look for recurrence of the known breast cancer if they had breast conservation, and to look for the emergence of a contralateral breast cancer because they have a higher risk, as we talked about, 0.3% per year. They need to have the preventive health measures that are appropriate for their age and their health status, cholesterol, blood pressure check, glucose, all those kinds of things. The kinds of exams that are required for gynecologic follow-up, evidence-based. But I think the key here is that there is no evidence to support routine breast cancer-directed lab studies or imaging in the absence of symptoms. So please, no PET CTs, you know, no bone scans, no x-rays. You don't need to do that liver function panel unless you want it for whatever you're investigating. From the point of view of monitoring a breast cancer patient for breast cancer recurrence, these things are not required unless she has symptoms or he has symptoms, or unless in the context of your exam, you find something that troubles you about the possibility of recurrence. Help us out here. I showed you the price of just my hormone therapies. You can give a lot of hormone therapy if you don't do a PET CT. So I think we can think very hard about how we use our resources wisely to maximize the well-being of our patients. So with that, I've covered topics that I hope are of interest to you and certainly have been interest to me. So I want to come back to my patient because I'm hoping you can tell me what we ought to do. So remember, she's got early stage breast cancer. She's premenopausal. She's got what we call a triple positive breast cancer, ER, PR, and HER2 positive. So what does she need from the systemic therapist? It's tough to be the chief resident, so I'm going to start with you. He's got the mic, too.
Lovely.
You're welcome.
Yeah, thank you. Well, so you said that she's hormone receptor positive and
Okay.
she has HER2 amplification, and she's early stage with node negative disease. And so I think that hormone-based therapy, endocrine therapy would be appropriate. So I think starting with tamoxifen would be reasonable. And then with HER2 over amplification, it seems that treatment of that with trastuzumab would be reasonable as well. I will leave it there.
That's actually fantastic. I guess you're going to put oncologists out of business, which really troubles me. But so this is actually what we did recommend to this particular patient. You remember I showed you that slide that talked about the possibility of using a slightly lower intensity chemotherapy with the trastuzumab. And so for this particular patient, we recommended that she would take anti-HER2 based therapy, as you described, trastuzumab with a single agent chemotherapy. And this 3-month regimen followed by the year of trastuzumab. Remember that the year is currently the treatment of choice. We didn't think her risk warranted the use of other HER2 therapies in addition, like pertuzumab or neratinib or anything like that. We thought those outcomes would be pretty good. She hasn't had a radiation, so she does need to have radiation to the breast. And so normally what we do is to give the chemotherapy first. She can then have radiotherapy during the time that she's continuing the trastuzumab. You point out quite rightly that she's a premenopausal patient, and so tamoxifen is the hormone therapy of choice for her. If this lady had been 10 years older and postmenopausal, we would have used an aromatase inhibitor. Because she's premenopausal, I would not use a bisphosphonate for management of her breast cancer, based on the data that I showed you today. it might be that she would take one over time for her bone health. And then, as we just talked about, she needs routine follow-up care at the end of this. No breast cancer-specific testing except for her routine breast imaging. So with that, I thank you very much for your attention.